board bombs.
Cold open. Let's rock and roll.
Cold open, start of the year. Well, I should say start of the year, but I was actually here alone last week, shivering.
You were like shivering
in the
cold,
winter.
shivering
Lonely,
in the winter. Like
afraid.
I had a mental image of you just like with a blanket on as you were recording that podcast, making yourself hot chocolate.
It was like the Call of the Wild, or with that Liam Neeson movie with the wolf, Grey Wolf, whatever it was. That was like me.
Yeah, we are Liam Neeson fans, although John Wick has supplanted him in our books.
Careful, Liam Neeson may come after you. He's a special set of talents or skills.
He does have a special set of talent.
Hey, welcome back. Hey, it's Ian Boarbombs. Oh, jinx.
Oh, jinx.
This is Ian Boarbombs. We are known for lots of things, and seriousness is not one of them.
Yeah.
We got an awesome action-packed 2-week special for you. Do you remember when you were a kid and you watched, let's say some type of superhero show or cartoon, whatever, if you were allowed to watch that?
Yeah.
And I could tell you grew up in a strict household.
Oh, yeah.
And
not everyone can tell.
Yeah. Yeah.
Even my residents.
Yeah, you definitely did. Yeah. Anyway, so if you were allowed to watch those shows, and don't you remember at the end of the show, it was like, to be continued. It was like the worst thing ever as a child.
It's
terrible. You were watching that, and you were really like, because back then you couldn't record anything, right? You had to just like catch it at the right time again on TV.
Yeah. Hey, let me tell you, it's still terrible when they do that.
Oh yeah, it's awful. You're like, where am I going to find this?
Right? It's like that Spider-Man movie that came out, the cartoon thing. I was like watching that, and they're like part 2. I was like, what? They're like coming back from the plane, and I was watching it on the plane. I was like, you can't just end it like this.
Hey, well, good news for our listeners and viewers. When part 2 is coming out to this episode, and it's going to be, I don't know, let's guess the week after this.
You got it. Hey, we are Ian Board Bombs.
We are.
I'm just going to dive into it.
Please,
we Ian Board Bombs. We drop 10, 15-minute long episodes of high-yield board content. We're the blue-collar podcasts. We also like to say, come for the STEM, stay for the content. Sure. I don't have where did my Nalgene bottle go? I can't show that off on YouTube.
The Nalgene.
We got a lot of really good comments on that last time we showed off that Nalgene.
Mine is not behind me right now. It's just the Yeti mug and the
I traveled.
mug.
I took that with me and traveled with it half across the world. The Nalgene, our Ian Board Bombs one.
Oh, nice.
I didn't know if it was like a good idea to fly with it, especially on a plane, because it does say like bombs multiple times on it. But I figure people look at me and they say, "Hey." Nothing to be suspicious of. Yeah. Anyways.
Hey, we got to give a shout out to our sponsor.
Oh, yeah, that's right. EM News.
EM News.
Done.
Yes,
they're
voice
amazing.
of the people.
Go check them out.
They're free.
Go sign up for a subscription. They're
totally
great.
Free.
Yeah, it's a free subscription.
You could argue that it's not free because you went through school to be an emergency physician.
Yeah.
And so it's not free. You have to go be an emergency physician first. But once you are, it's free.
Yeah, once you are, it's free.
Once you are free.
It's like a perk.
A free subscription.
Come and get that perk. Hey.
It's awesome.
Let's go on to the STEM. A 33-year-old male presents to your ED with the chief complaint of, quote, slow heart rate. For those watching on YouTube, yes, I'm doing air quotes. He states he just got an Apple Watch and he used the EKG feature to make sure that his heart was in, quote, good health, end quote. He states that the heart rate showed 55 and had a bunch of, quote, squiggly lines. He states that the watch told him that he didn't have AFib. That's good. But when he looked up a normal heart rate on ChatGPT, he was told that he had a condition called, quote, bradycardia. When he asked ChatGPT what causes, quote, bradycardia, one of the responses was heart disease. He called the triage line at his PCP's office. They were not there during the weekend, unfortunately. Told him that he should go to the ER for his bradycardia. He's worried that he has heart disease and would like you to evaluate him for this. On physical exam, his heart rate is in the 50s. Vitals are within normal limits. EKG shows sinus bradycardia. The rest of his physical exam is benign. He denies any chest pain, syncope, or pre-syncope. He's an avid jogger and denies any current symptoms. And while you're talking to him, he gets a call back from his actual PCP who tells him he should probably go home. But patient says again,
said
he would
no
like
one
to be
ever
evaluated. He says
but it was actually 6:30 p.m. and the physician's office is closed and it's a Friday.
What is the next best step? A, give patient a Zio patch. Is it Zio or Zio? Whatever.
Well, it also depends where you're at because it's called many different things in different areas of the country. How about this? Give patient a portable heart monitor.
There you go. That? B, send patient his PCP for further evaluation of his bradycardia. C, have patient follow up with cardiology for an echo. Or D, reassurance. Hey, Briggs, what's the correct answer?
I'm going to go with choice D, which is just reassure the patient.
Just reassure the patient. Hey, we're going to get into this because I think this is really important, bradycardia. You picked this topic. The first part of it's really going to be just sinking into it, really understanding what causes bradycardia, some of the etiologies behind it, because that's really what's going to help you with treatment. Before we do that deep dive, EM Rapid Bombs, right? Go to our website, emboardbombs.com, and then you'll find our EM Rapid Bombs podcast. It's a 2-click sign up. It's pretty awesome. Right. We have more than 400 episodes now. We've got a bunch of residencies that have signed up too. So if your residency is interested, feel free to reach out to us. We do group discount plans, et cetera, et cetera. A lot of people studying for ITE. We've seen a huge uptick in the number of listeners and the amount of content that's being consumed recently. So again, emboardbombs.com, and you can reach out to us directly if your residency wants to jump online. The coolest thing though is about a third of our folks are folks that actually aren't in residency. They're practicing EM docs, and they want to continue to get multiple podcasts delivered to their inbox that help them keep up to date with content and knowledge. Okay, hey, Briggs.
It's time to slow things down here, if you will. And talk about bradycardia.
Oh, it's still not as good as the diarrhea episode.
Anyway, the C. diff episode is the best.
There are 4 major steps in evaluating bradycardia.
Go. I'm going to hold fingers while you do it.
Stable versus unstable. Symptomatic versus asymptomatic. Determine the autonomic location causing the bradycardia. So there are 3 main ones. SA node, AV node, or the His-Purkinje system.
You did a good job with that.
I know, I did fantastic. 4, assess for secondary causes of bradycardia. We're going to have a mnemonic that we're going to be dropping. That's pretty good.
Yeah.
Hey, a lot of healthy people have bradycardia. Resting heart rates can be in the 30s, with no symptoms. These patients, they're not going to require intervention.
But they're going to come to your ED.
I know. They will. That Apple Watch will tell them to come. And I will tell you, their primary care doctor will tell them not to come either, but they want that ER
But the nurse over the phone will tell them to come.
Oh, man. Oh. So, listen, the heart rate alone is almost never a sign of instability unless there are other factors at play. This is what's so critical. You cannot get focused on a number. Sure. I care more about the patient with the heart rate in the 70s who's diaphoretic than the one who's hanging out with the heart rate in the 40s and looks great, right?
Playing Candy Crush on their phone.
There you go. So again, heart rate alone is not going to be a sign of instability unless there's some other things that are at play, such as underlying vasodilation, negative inotropic effect, or intrinsic cardiac disease. Hey, get into it, Briggs.
I love this next one. Progressive bradycardia is a lot worse than what it sounds. Also known as about to die bradycardia. Yeah. If you have
I think every ER doc in their career has experienced this. You do this long enough, and it is that crashing airway, right? It's that patient who's already hypoxic, and you just immediately that patient is super tacky. They're crashing. They're already half. They've been resuscitated at some point, right? And now they're in your ED, and then somebody makes the comment to you, "Oh, great, the patient isn't tachycardic anymore."
And then you notice their heart rate go from the 50s to 40s
as an
to
ED
30s
doctor, like,
to
that's
20s.
Not good.
Yeah. This is a sign of pre-arrest. This is never normal.
Right.
If you have a heart rate that's progressively lower,
right,
then that's a problem.
That's a problem.
Speaking of that, symptomatic bradycardia, it sounds silly, right? Because you're thinking, oh, I know what that is. That's just, I'm feeling weak and I have a low heart rate. That's not necessarily true.
Yeah.
Symptomatic bradycardia exists when the following 3 are met, meaning that the bradycardia is causing this patient's symptoms. 1, their heart rate's, you're doing the fingers.
Hey, by the way, some of the shorts that Alexandra has done amazing. With like the
gold
eyelashes and what in the world is this? This is
they're great. People are eating it up at my workplace.
I'm a professor at Wake Forest University School of Medicine. Okay, and I've
not
got
sponsored, by the way.
like
We're not associated.
that's what, yeah, and I've got like eyelashes coming out from my eyes. I'm doing TikTok. What is this?
Yeah.
What have I become?
Yeah, make sure you put that in your promotion portfolio for professor.
Okay, my residents and medical students need to take me seriously. Okay, I cannot believe you guys. You guys are just having way too much fun.
Speaking of sponsorship, ignore the massive UT orange letters on my sweatshirt.
Yeah.
Apologies to other SEC schools. Alrighty.
Yes.
Hey, so symptomatic bradycardia. It exists when the following 3 criteria are met. 1, heart rate is slow. 2, the patient has symptoms, actual symptoms. And 3, the symptoms are due to that heart rate. I know that's a little, I don't know, haiku-ish in a way, but the whole point of that is saying that the patient has a little heart rate.
Did you just say haiku?
Yeah, it's a little haiku-ish, it's like a haiku. The heart rate is slow. The patient has symptoms. The symptoms are due to the slow heart rate. Anyway, the whole point of that, though, is that just because they're bradycardic and something bad is going on with them doesn't always mean that they actually need to be treated for that bradycardia. But they actually have to be related. So on that note, let's talk about the cardiac output.
Yep.
So cardiac output equals what? Stroke volume, heart rate. Perfect. Yes. That's all you need to know. But the problem is when you have a decreased cardiac output, when a patient is in bradycardic shock, they will manifest as what? Hypotension. Typically, they're going to have some type of decreased organ perfusion, altered mental status. Hopefully these things are obvious for you that you don't have to think about it. Chest pain, dyspnea, syncope maybe, where they came in or near syncope. Doesn't matter. These are all signs of an unstable bradycardia patient that needs rapid treatment. Now, some patients might confuse you. They might have a normal mental status, but on your exam, they're going to have cool extremities, sluggish cap refill, distal pulses that are sluggish, whatever. These patients are also unstable, even though they're mentating normally. Okay? They could be texting on their phone, but you touch their foot and it's cold, or their hand and it's, a bad radial pulse. That's bad stuff. That's not good.
Bueno.
Yeah. So the next thing is, where's this bradycardia coming from? Of course, you're getting an EKG, and through the EKG, we're going to really simplify this. You're going to look for a wide or narrow QRS. It's kind of like with tachyarrhythmias, right? We learn the same thing. We've talked about the same thing on our podcast. We have a handout on our website for tachydysrhythmias, and it's the same approach, right? How to treat tachydysrhythmias. The first 2 steps are what? Wide or narrow QRS, and then it's regular or irregular. And that tells you pretty much 90% of the information you need to know.
Yep.
Same thing here. Even simpler. If you have a narrow QRS, which the majority of bradyarrhythmias are, it's simple. It's coming from the SA node or AV node of some type. These are classic blocks you learned in medical school. Most of these patients respond well to meds like atropine, epinephrine, et cetera. Usually, I'd say we're going to have a caveat in the next episode. If it's a wide QRS, you're thinking about the ventricles. You're thinking about the His-Purkinje system, which Dr. Hussein pronounced so well a few minutes ago. And like most arrhythmias that have a wide QRS, really bad things are happening.
Yep. I like how you're just breaking this down too. It's like narrow or not narrow.
Yeah, that's it.
And then we're going to, and then you're about to say something really important.
Yep, exactly. These patients with wide QRS, bradyarrhythmias, they do not respond well to meds.
Huge.
So like atropine, epinephrine.
Please repeat that.
They need pacing. Can I say it louder for the back?
Please, for the back.
For the back of the room. For those of you who came in late.
Yes.
I'm going to tap the desk with my ruler.
Yeah. For those of you that are jogging right now aggressively and just missed
Pause for a second. Pause. Do a calf stretch. Pause for a second. Calf stretch. These patients with a wide QRS and bradycardia, these patients do not respond well to meds typically. They will need pacing.
There you go.
These are sick people.
Yes. This is not one of those where you're like, let's try a little of atropine and wait a little bit.
Atropine and chill?
Yeah. Not a thing here.
Hey, the following rhythms are absolutely what you need to know. You have to know these rhythms. I'm sorry. Yeah. And it's a podcast. We can't show them to you, but you have to know these rhythms as an emergency physician. You should look at the piece of paper and say, oh, that's this. And you look at it and you know exactly what it is. What are they, Dr. Hussein?
Hey, and you can go to Life in the Fast Lane.
Yeah, easy.
Shout out to Life in the Fast Lane. I think it's from our Australian colleagues.
Those Australians.
They're just great. They're amazing. So they've got a great kind of EKG portfolio for ED docs, like what ED docs actually need to know. So the ones that we're going to get into here, junctional bradycardia, first degree AV block.
Easy.
Second degree AV block.
Easy.
Complete AV block.
Easy.
Ventricular escape rhythm and complete heart block.
Sometimes easy.
Yes, usually, especially the latter.
Usually.
Bradycardia induced torsades.
Easy.
Yeah, easy. Brash syndrome.
A little more technical.
Yeah, that is. And then obviously sinus bradycardia.
Oh, yeah, I forgot that one. Hey, so what about the other causes of bradycardia? Do you want to do the mnemonic that I came up with? I came up with this mnemonic when I was in med school.
It's all
No, I
you.
want you to do it.
No, you because you're just so excited about it. I know.
Well, don't you like it?
It's great, especially like the two MI ones that you mentioned. I thought that was like
you have to remember it twice.
That was very Briggs.
Whatever that means.
Nothing.
Oh. So I'm not the biggest mnemonic guy. I'll preface with that. When I was in, what was that for?
No, you said you weren't a big mnemonics guy.
Well, I don't use them much anymore. I like to think about things, but I feel like in critical situations you need to memorize them as much as possible. Yeah, you don't. So the mnemonic is atropine. So if you can spell atropine, that's all the letters of atropine are the mnemonic.
There you go.
So let's go through it. A, anterior MI, easy. T, thyroid disease or adrenal failure. R, any rhythms. We talked about that already. O, overdoses. So these are straightforward. Beta blockers, calcium channel blockers, digoxin, sometimes clonidine, sometimes amiodarone.
This is going on our short.
P is pressures. So we think of intracranial, pressure. I, inferior MI. N is my favorite, numb or nippy, which is hypothermia. Dr. Hussein loves that one. And then E for electrolytes, perhaps the most common one, potassium, calcium, magnesium. So, Dr. Hussein, why don't you delve into this and sort out of that mnemonic, which are the ones that are so critical that you should walk into the room, you see unstable bradycardia, you say, here are my top 4 right now. If I miss these, the patient's going to die.
Yeah, so there's top 4 here. Hyperkalemia.
Let me guess what number 1 is.
I mean, honestly, like hyperkalemia, it's just the easiest thing to at least stabilize, right? And you just don't want to miss that. That's like the worst way. You are not allowed to die in the ER from hyperkalemia. That's just like it's like trauma surgeons say everyone gets a chest tube, right? In some of those like blunt traumas that are arrest, it's hyperkalemia. So that's number 1.
Right.
2, MI. There's a reason why Briggs listed MI twice. 3, tox. If you don't think of these, the patients are just going to die, right? This is going to take you down a completely different pathway.
Correct.
So remember some of the tox things we talked about, that overdose, right? And the atropine, that was the O, so beta blockers. And we actually have a couple podcasts on these, right? So beta blockers, calcium channel blockers,
digoxin.
Yep. Yeah. Clonidine. Clonidine is another one that I think a lot of people forget about, right? Sneaky. And then amiodarone as well. All right. So that was tox. And then lastly, the 4th one. So intracranial pressure.
The most random one ever.
That's very random. That's the one that's EKG is going to show. Ischemic changes, deep, large T-wave inversions.
Scary deep T-waves,
right?
Yeah.
But especially those first 3, I think, are absolutely critical. The hyperkalemia, the MI, the tox. The more rare ones should be thinking about, like include hypothermia, right? Mixed edema coma. And then a heart pathology like endocarditis or Lyme disease.
Yeah. It's very common to diagnose hypothermia with an EKG. I do it all the time.
All the time.
During the thermometer shortage of 2019.
Of 2019. Yes.
Hey, part 2, are you ready? To be continued.
To be continued. Hey, that's it.
Alexandra needs to cue some dramatic music at the end here.
Yeah. Will this 33-year-old patient make it in the ER?
Will he be reassured or paced?
Will he leave you a good comment on Prescaney scores?
Or will you be fired?
Upset that he did not get an echo immediately?
Yeah. Or will Jaco intervene?
Jaco.
Because you left your drink on the table with the lid off.
With the lid off and in the inappropriate place. And a code card was not placed fully against the wall.
There was an inch space between it.
Now your ED must be shut down and diversion must occur. But diversion cannot occur because you are the only ER that is already understaffed.
That's it.